Hi, everyone. We're going to wait for some more participants to join us, so stay tuned. We'll start in a few minutes. Hi, John.
Hi, Ashley. Hi, Catherine. How are you?
Doing well.
We'll give it maybe one more minute and then I can introduce Catherine. And John, if you wouldn't mind letting people in from the waiting room as I'm giving her intro, that would be great.
Sure.
Okay, well, welcome everyone. Thank you for joining us today. I'd like to introduce you to Dr. Catherine Lau. Dr. Lau is a professor of clinical medicine at UCSF and a member of the Division of Hospital Medicine since 2009. She currently serves as the Director of Caring Wisely at UCSF Health, where she focuses her efforts on redesigning and innovating systems of care to improve quality, safety, value, and the patient experience. Catherine is also the co-director for health systems improvement in the clinical microsystems clerkship at the UCSF School of Medicine, where she co-leads experiential curricula for preclinical medical students to gain meaningful experiences in health systems improvement and A3 problem solving. We are so excited to have Dr. Lau join us today. Welcome, and I will turn it over to you for your wonderful presentation.
So thank you so much for that warm introduction, Ashley. I'm so excited to be here virtually with you all today. And speaking about a program that I've been involved with for over a decade now, and have helped to lead over the past 8 years. And I hope to keep this interactive, so please put in questions in the Q&A as they come up, and I'm happy to answer them. And if at any point anyone wants access to any of this material or slides, you can also feel free to reach out to Ashley and I as well, and I'm happy to get you the materials. So specifically today, I'll be talking about advancing our healthcare system delivery to become a higher value system through innovative approaches and techniques and through the use of implementation science coaching. So the objectives for the webinar talk today are to introduce you a bit to this program called Caring Wisely, why we started it and what our objectives are, and allow you to understand how we meld a couple of different tools and ways of problem solving, whether it's implementation science, A3 thinking from lean methodology, and human-centered design, to really help drive effective deployment of innovations in our health system, and also importantly, drive measurement to understand what our impact was. And I hope to highlight at least 2, if I have time, 3 Caring Wisely projects, but I aim to start with 2 just in case there is a good amount of Q&A and discussion as well, and describe some of their outcomes. So Caring Wisely started about 13 years ago with some seed funding from the Center for Healthcare Value at UCSF. And the rationale really was this. We know that as academic medical centers, we are the heaviest drivers of healthcare costs in this country. And a lot of it is totally reasonable, right? We are tertiary, quaternary care centers caring for some of the most vulnerable and some of the most complex patients in our country, and sometimes even internationally as well. And yet we know that we also serve a fair amount of bread and butter diagnoses, and there are lots of opportunities to improve both our quality, but also importantly, control our costs. And we also know that the more interventions that happen, this can lead to local savings to our health systems. And so what we did was we presented this to our C-suite and said, look, if you decide to fund this program after the seed funding runs out, we will pass on all of these local direct cost savings to you. And we will show that there are ways to save money that you will be able to benefit from at the end of the year, and therefore return on investment from you supporting this program and supporting our teams. We also know that in healthcare, oftentimes there's this top-down approach where leaders or managers will tell the folks who are doing the frontline work, hey, you know, this is what we're gonna do, and therefore you must do it. And there are some systems that are incredibly, incredibly successful at that approach. A really big example of that would be Kaiser Permanente, for instance, that tends to be a lot more top-down. However, maybe because it's the ethos of who we are at academic medical centers, that approach doesn't always work all so great, at least at UCSF. And we know that many of the successful interventions that we've had have had really, really engaged front lines. People who may have even come up with the ideas, participated in the problem solving themselves, participated in the brainstorming and the design of the interventions. And that whole idea of just being top down doesn't work so great. So we decided in Caring Wisely, we would be really intentional to crowdsource and harness all of these wonderful ideas for waste opportunities and to curb that waste from our front lines. And I'll describe a bit more about how we do that. So our main objectives are to identify the hotspots for utilization. I'll describe this heat map in a little bit further detail in an upcoming slide. But briefly, this is a heat map of packed red blood cell transfusions in the adult hospital. And once we identify these hotspots of value improvement opportunity, we then encourage these teams and eventually fund them through Caring Wisely, which is a collaborative opportunity for these teams to participate with us in designing and implementing and measuring their ideas. And ultimately, by the end of the Caring Wisely year, we are able to measure a return on investment for our health system. And the return on investment can be the actual direct cost savings dollars. And our health system, and I'm sure yours would also be really interested in other metrics as well, such as quality metrics, patient's experience, provider experience, et cetera. This is our team structure. So I've been the director since 2016. The initial director is now one of our executive sponsors and our chief innovation officer at UCSF, Dr. Ralph Gonzalez. We also have a co-executive sponsor who is our chief clinical officer, Dr. Josh Adler. We have committees, so an executive committee that meets quarterly, where they are the systems leaders in our very large health system who hear updates on all of the different projects, and also importantly help serve as executive sponsors and remove large system barriers for the implementation of any of these projects. We also have a selection committee that meets during our annual project contest to select our 3 projects every year. We have our implementation science advisors, Dr. Bosgarden, as well as Dr. Gonzalez, who wears another hat, is still one of our implementation science advisors. We have our human-centered design expert and service designer, Jan Yeager, and also a lot of collaboration with our health system value improvement program to allow us to measure the direct cost savings to our health system. And last but not least, where I probably should have started to begin with, the heart and soul of Caring Wisely honestly are our project teams and leads. They are the reason why we are here, and they are the reason why we've had all the success that we've had. So how do we engage frontline teams to identify these hotspots of value improvement opportunity? We use an online platform that was developed through our CTSI program. and is now implemented through our IT department. It's called Open Proposals. And it's essentially an online platform where people submit their ideas. It's similar to like a Twitter, or I should say X now, or Facebook page, in that people can go on and like different ideas. They can go on and comment and ask questions of the folks who submitted the ideas. And it's really an opportunity for our UCSF community to gather on this online space to both submit ideas and also have an opportunity to participate in discussions about the ideas that they've submitted. So over the past 13 years, we've generated over 220 ideas. Unfortunately, we are unable to fund all of them. The funding comes with $50,000 to spend over the implementation year and comes with a lot of coaching, project management support, and data support that I'll describe in a bit. The project contest that we launch every year is about a 2-month iterative process. We have a first phase as well as a second finalist phase. And as I was describing to Ashley earlier, we do a lot of key stakeholder and financial vetting during this time. So our selection committee consists of many different members representing all the different areas and service lines in our hospital to make sure that these ideas, not only are they important to our health system, but that they are able to be feasibly implemented within 1 year. There's a lot of multidisciplinary team building that happens. And as I mentioned, about 3 awards, or actually definitely 3 awards, are selected for the $50,000 funding every year. We are really proud to open up this opportunity to our entire health system. So we have funded projects spanning in the adult, pediatrics, peri-op, ambulatory, inpatient, laboratory, pharmacy settings. We represent 3 of our schools here. We've had projects funded where the PIs come from the School of Nursing, School of Medicine, and School of Pharmacy. And the project leads have also importantly been interprofessional. It's not all just, physicians. And also importantly, some of the project leads have also been trainees, so either fellows or senior residents, many of whom end up going into a chief residency year. So I described that we have this executive committee, and it's a lot of members of our C-suite. So the chief clinical officer I mentioned, oh yes, go ahead.
I'm sorry, very quickly. Are staff eligible to apply for these proposals as well?
Yes, absolutely. Staff are eligible to apply, and I neglected to say that some of the staff that have been funded were improvement specialists or people who lead quality improvement work or value improvement work in their respective areas.
And do you have any sort of a second tier award for maybe very small projects that may not need $50,000? Maybe a $5,000?
We don't yet. So there are other opportunities in our health system to have this, to get other modes of funding to do value improvement work. So sometimes projects that aren't successful in being funded, we refer them to other contests or other folks who may have funding available that is a bit smaller. So there are those opportunities, but we don't have that tiered level yet in Caring Wisely.
Thank you.
Yeah, you're welcome. The thing I really want to highlight here is all of the support in addition to the $50,000 that the teams get. So we meet with them every week initially for the first 3 months of the Caring Wisely year, as we're really designing and understanding the current state, understanding the problem, doing their gap analysis. That then switches to meetings with the teams twice monthly in these works in progress sessions. So there is quite a bit of coaching involved, much more so than a traditional grant where you kind of get the money, you do what you promised to do, and you come back kind of the end and write your final report. So it's much more of a collaborative process. We also coach people on project management. Many teams come with their own project managers, some don't, and we may have to locate those resources for them. But we do provide them a lot of project management tools. We give them access to data. Most teams want access to our EHR Epic data. We do theory-based intervention design that I'll describe more in detail through implementation science principles. And we implement. We do a lot of rapid plan, do, study, act over the course of the year. So here's that heat map again. And this was one of the first Caring Wisely projects that was selected. And the goal was to get our packed red blood cell transfusions in our adult hospital to evidence-based guidelines. And what we found was of all of the different services, each box consists of one attending physician. There was a lot of variability within groups even. Some groups like hospital medicine, the paler the box, the closer you were to the hemoglobin level of 7 or less, which is the evidence-based guideline unless someone truly is having active myocardial ischemia to transfuse someone. So once you were this light pink, you were pretty darn close to that guideline. But you could see even within my group, some people were transfusing a lot more at higher levels. And sometimes it makes sense if you've got someone perhaps with an active GI bleed, but there were a lot of opportunities across our institution. And doing this sort of heat mapping and data analytics support mined from our EHR was really helpful for this team to be able to go out and do the academic detailing they needed and create a sense of awareness, but also some friendly competition amongst groups and also within groups to change behavior. So one example of how we utilize data analytics. In terms of how we really apply theory-based intervention design, there are so many different implementation science frameworks, and the one that we use the most is the pre-seed, proceed model, which I'm really going to boil down to 3 main things that makes a lot of sense. The whole idea is if you're asking someone to change their behavior, what themes do you really need to target in order to be the most successful at changing that individual or team's behavior? And one of the things we really talk about, one big bucket, are what we call the predisposing factors. It's what do people need to know? What attitude do they need to have? Or what motivations do they need to have to be able to want to change? So the example of packed red blood cell transfusion, the knowledge might be, wow, I am not following evidence-based guidelines compared to my peers. I do want to change. This seems like a really great opportunity to change where I'm not going to be shamed, named, and blamed. But I just want to practice better evidence-based medicine. The second group of things we really think through are what are those enabling factors that will enable behavior change? So what needs to be facilitated, sometimes even automated, make things easy, and sometimes make the wrong thing to do almost impossible to do in the workflow or in the EHR. What do we need to integrate or change within the workflow in order to allow this change to happen? So that not only do people want to change, but they're like, oh, it's relatively easy to change. It's not as painful as I thought. And then the third thing we really think about is what do we now need to reinforce? So it's that dopamine kind of release, it's like, what reward are you giving people? Are you giving people audits and feedback of their data? So you can't just show them one heat map at the beginning, ask them to change, and they never come back again, right? So it's like regular feedback of data. Sometimes getting operations leaders, maybe it's the medical directors, the unit directors, the clinic directors, whoever it may be that people are reporting to, really also cheerleading and messaging the work as well. So at the end of the day, people not only want to change, they feel it's relatively easy to change, and they also really like it too. So this really is the heart of what we try to understand in the first few months of our Caring Wisely program. We try to go through and think through, okay, we know we have a quality gap. Why do we have this quality gap? What gaps do we have in knowledge, attitudes, and motivation? What gaps do we have in enabling factors? And what gaps do we have in reinforcing factors? And then once we understand the gaps, we then design our experiments or what we want to implement under, what things do we need to do to change knowledge, attitudes, motivations, so on and so forth. So I'll show you an example. This is really busy. Please don't read everything. This is a project that we supported 2 years ago, funding a community-based worker, an inpatient health advocate who identified as Black, to proactively round on our Black inpatients on the hospital medicine service. And the goal was to improve patient experience, reduce readmissions, promote adherence to treatment plan. And so the team, we used Google Jamboard, something relatively low tech, and we just said, okay, like what's the behavior change that we're asking people to do? And one of the things we brainstormed around was having the medical teams being accepting of having a health advocate as a part of the team to increase patient agency. And we thought about all the knowledge, attitudes, and behaviors or motivation that people needed to have in order to predispose them to want to participate in this, what needed to be enabling to allow the health advocate to be an acceptable member of the medical team, and what needed to be reinforced. Again, busy slide, but what I want to mostly highlight in here is how the predisposing, enabling, and reinforcing, we call it the PER, is really baked into everything we do in Plan, Do, Study, Act. So under the planning, that's just what I showed you in that Jamboard. It's like we need to understand like what our target behavior is and what are those predisposing, enabling, and reinforcing factors that need to happen. When we intervene on the target behavior, we roll out things that address those predisposing, enabling, and reinforcing factors. We study the impact of that, and then we plan our next PDSA cycle. The next thing I really want to speak about that we utilize in implementation science is something called a logic model. And for those of you who do more traditional QI, this is very similar to what's called a driver diagram. So it's just a way to measure process evaluation and allows for a graphical display of what you're putting into the program and connect it one-to-one with what you're actually doing or rolling out, which is your process measures, and eventually connecting it to what outcome you are aiming to achieve. And it allows for a really nice roadmap for causal relationship without having to conduct a randomized control trial. Is generally pretty acceptable, especially to those working in quality and the C-suite, so that they're able to see this like logical map of how the things that we're putting into the program, what the program is doing, will eventually impact those outcomes. So very quick example of what I mean by that. So there's the inputs. Generally in Care and Wisely, we don't talk about the inputs so much because we already told the teams up front, this is what we're giving you. But in case you're wondering, it's usually the money, staff, equipment that is needed to roll out a program. And then the outputs are what are those activities the program ends up undertaking. Sometimes it's training, education. A lot of times it's EHR modification, maybe new workflows. And then eventually, how do those outputs then impact the process? So what eventually is produced, how well are those actually being implemented and adhered to? So number of workshops held, people trained, user satisfaction, are people actually using that new order set that you had built? And ultimately the outcomes that you're hoping to impact. So as an example, connecting it back to that inpatient health advocate program, I'll just go through the top. Again, we don't really talk about our inputs so much in Caring Wisely, but we tell them to frame like, what are your overall goals? So one of their goals was to improve patients' understanding of their illness and care plan. And so to do that, the activity was the proactive rounding with the health advocate, partnership with them, teach back patient education while they were still hospitalized, linking that then to the short-term outcomes of how many patients were matched to a health advocate, patient satisfaction scores and surveys, and ultimately to the longer term outcomes with those press gaining and HCAP scores that get eventually reported back to us. Last but not least, before I highlight two specific programs, I just want to give you an example of what our human-centered designer really contributes to our program. So human-centered design alone could probably power a similar program like Caring Wisely. And where I would say we really utilize our service designer for is doing deep empathy process mapping exercises, where she really goes and works with the teams to understand the current state, and then really goes and brainstorms with the team to then mock up and visualize and prototype what our interventions might look like. So here is an example of an early mobilization program in our pediatric ICU. where we already had one in our adult ICU and just weren't doing it in our kids. And so just thinking about how are we going to get these really critically ill patients to mobilize even when they're on a ventilator with our therapists. So here's an example of a high level map that our service designer creates. And then she's able to then create really detailed maps, like step by step, everything and all the different individuals who are involved. And this really is worth its weight in gold, because oftentimes you can sit in meetings and talk about what you want to do and how you're going to change things. And it's not really until people start visualizing it, and even before she puts it in this final format, like poster boarding it, workshopping it with Post-its, that people really crystallize and understand, okay, this is where we want to go. This is what we're going to be changing. Here's an example also of something she helped us create for this team. It's called a Move Your Body worksheet that our child life services use to support the patient and family prior to and after mobilizing. And communication boards were also used as well. And we posted these also in the room for their daily mobility plan. Okay, I'm going to pause here before I jump into two more specific projects fairly quickly and high level, see what questions there may be. Okay, I'm going to keep going then. So this is a project that we supported, and I chose this one because it's an example of a clinical pathway redesign and innovation. The next example I'm going to choose is an example of overutilization and wanting to reduce the use of, in this particular case, a drug in our health system. So this project was led by one of our nurse practitioners in very close collaboration with the neurosurgeons that she works with. And the background to this project was, at least at our health center, all post-craniotomy patients are recovered in our neuro ICU. And we have a very large neurosurgery center. We're the largest center west of the Mississippi. They have 3 neuro ICUs. And you can imagine with the volume that they do, all these people need to go to an ICU bed afterwards. And I used to do a fair amount of neurosurgery co-management, and it was always very striking to me that I would go around on these patients and, they're sitting, playing on their cell phone, calling people, and they look very different than a patient who might otherwise need an ICU bed. But it was a mandatory thing because these patients needed every 1 hour neuro checks, which couldn't be done anywhere else in the hospital. So there was a bottleneck waiting for ICU beds, and case delays, and a surgeon's worst nightmare, which would be possible cancellations. And the context here was, at that time, our new Benioff Children's Hospital was opening at a different campus, and all of a sudden we had these new units where the Children's Hospital used to occupy in our hospital tower that were opening up, and we acquired 20 new transitional care unit beds. So this is a step-down unit between an ICU and an acute care level bed. So there was an opportunity to utilize these beds a little bit better. And so what the neurosurgeons and this nurse practitioner proposed was for more simple, relatively simple craniotomy procedures of smaller tumors, younger patients, shorter surgeries without concerning medical comorbidities or any intra-op untoward events. These patients would go instead to the PACU immediately to recover, like most surgical patients, before then going to the transitional care unit and eventually being discharged home. So completely reinventing the way we were providing neurosurgical care. And when they were coming up with this, they obviously wanted to make sure there were other large centers who were already doing this. It turns out in the UK, they already do this very routinely, and also large centers in Canada as well. So here are examples of the predisposing education factors and knowledge, attitudes, and motivation that needed to change. These are examples of the enabling systems factors, workflow factors that we worked on to change in order to enable and facilitate the behavior. And here are examples of the reinforcing measurement, audit and feedback of data sort of things that we did with the team. So again, you're going to see predisposing, enabling, reinforcing coming up a lot. And what ended up happening? we ended up saving a lot of ICU days per case, and 93 patients that initial pilot year went through this new pathway and ultimately saved a little over 100 ICU days. But also importantly to the health system, we call this pathway STP, or Safe Transitions Pathway. The patients who went through the Safe Transitions Pathway on average stayed in the hospital a little bit less as well. So that was also important for our hospital executives to know. And this direct cost savings that we were able to calculate with our finance team persisted even after adjusting for case mix index, procedure type, time variation of the OR case itself. And we were able to realize an actual direct cost savings to our health system, not even to the payer, but just directly to our health system of a little over $4,000 per case. And I also want to highlight that many of our teams ended up publishing in the peer-reviewed literature, and this was published in the Journal of Neurosurgery. So an example of working with a motivated team who identified an opportunity, a hotspot, found that maybe there were other ways to conduct this care that weren't already otherwise embraced in the United States, and piloting it with us. I should also say we also followed a balancing metric. So no patients died as a result of going through this process. There was, over the course of that year, one patient who needed a transfer to the ICU. It wasn't related to a neuro cause. It was related more towards an unrelated cause. If I recall correctly, it was more around a respiratory issue. So the next project I want to highlight before I then pause, and I have a third up my sleeve too in case there aren't too many questions, is improving the use of IV acetaminophen stewardship in pediatric patients. And I don't know about y'all here in Michigan, but goodness gracious, here at UCSF, we use way too much IV acetaminophen, or I should say we used to use way too much IV acetaminophen. When we started this project a few years ago, and we benchmarked ourselves on Vizient, we were #2 in the country, where being #2 in the country was actually bad. And we were only behind Duke University. So we were using way too much. And there was already work in the adult hospital to promote stewardship of IV acetaminophen, but it hadn't started in the pediatric hospital yet. And so the goal of this project was really to reduce overall IV acetaminophen use in the children's hospital by 30%. And they had a couple of main areas of work that they really wanted to focus on. So optimizing the use of enteral or oral acetaminophen, which is much cheaper, on the order of like 2 to 3 cents per pill, as opposed to $18 per dose or vial. Reducing the waste. So the way this comes from the manufacturer is it comes as 1 gram, which is fine for adults, but in children, that's way too much. And they end up wasting most of the vial because you can't just save it and reuse it for pharmacy regulations. So we were throwing out a lot of IV acetaminophen as well in this patient population. Sorry, excuse me. And then obviously wanting to maintain pain control. And so we were making sure that we weren't then just using a lot of IV opioids or PO oral opioids as a result. And so we wanted to follow that as a balancing metric as well. And so the team did a lot of focus groups, and they utilized the 5 whys analysis to figure out, well, why are we using so much IV acetaminophen? And at the end, we were able to kind of group things down into knowledge. So getting again down to predisposing factors, technology, decision support, enabling factors, as well as workflow, which is also another enabling factor as well. And based off of those gaps that we identify, the team then designed countermeasures or different experiments and tactics, and again, coded them as either an enabling target, a reinforcing target, etc. And here is just an example of how sometimes we pick chart things to decide what are the areas that we really want to focus on first to roll out and implement, and what do we need to start working on that's going to be of high impact, but also pretty high effort. And so what they were able to do was start their education campaign pretty early on in the Caring Wisely year. We built new orders for standard IV doses in mid-November in our EHR, did a lot of social gamification, audit and feedback of data between our cardiac and pediatric ICUs as well. And there was a dip in the use of IV acetaminophen. But what really caused things to change was when there was enough buy-in for us to change the formulary change in IV acetaminophen. It used to be that people could order it whenever they wanted. And now the current state that we've moved to is people can order it as a one-time dose, only if their patients are strictly NPO and aren't taking any oral enteral medications. If they are taking other oral medications, they then have to put in a non-formulary request. And even for these patients, a non-formulary request does need to be submitted and approved by pharmacy. And once we put this restriction, you can see the use of IV acetaminophen, and in terms of our trended invoice spend and how much we're spending on it every month really plummeted. But it took a while to build up to this point. It was actually done in year 2. So after the Caring Wisely year had finished and people had studied the results and realized, you know, we weren't hurting our kids, we weren't relying more on opioids, that people were okay with this big change. And again, just measuring direct cost savings or how much we were spending on IV acetaminophen in this patient population. There were some good changes in that first year, but really when that big workflow change happened is when we saw most of the cost savings. It's a lot of money, almost $700,000 on just one drug that you're just like, it's just Tylenol, but it costs a lot of money. All right, I'm gonna pause here before I continue, and I'm gonna see if I can stop sharing so I can see all the questions.
I can go. I have a question. I can go ahead and ask
Yes.
while we're waiting for some others. I think one of the barriers we've seen is, you know, staff is time. Staff having the time to implement these changes, and it sounds like you have a really great team that helps with the project management and helping with design some of these, some of the workflows and the analyses. But have you encountered, you know, these kinds of barriers in terms of getting staff time, and how have you combated that at UCSF?
That's a great question, Ashley. So yes, time is always number one, the big gap or big barrier to doing this work. The way we've addressed it in Caring Wisely is those $50,000 I had mentioned, the vast majority of it ends up paying for salary support for the project lead or leads. There are sometimes dollars earmarked for like education materials, pamphlets, maybe gift cards to promote behavior change, but people aren't spending $50,000 on Starbucks gift cards. They're generally spending like $40,000 of it on salary support, whether it's the project lead or their project manager to pay for a portion of their salary dedicated to this work for the year. Another thing that we do during the vetting process is, let's say, for instance, the project lead is an attending physician. We go to their division chief or their department chair and say, hey, are you in support of this person dedicating a part of their time next year to doing this project? And actually the division chief and department chair have to sign the award letter, basically committing their support to support their faculty member in doing that. Similarly, for like nurse practitioners, advanced practice providers, we go to their manager and make sure that they are supportive of this person dedicating a portion of their time, so that they're not then feeling like they have to work 130%, right? And they're adding it and burning the midnight oil. So that is something we do deliberately up front, even before the projects are selected. Generally, we have not run into issues where people, their managers say, no, we can't do this. Sometimes we have had to think creatively. So the pediatric early mobilization program, as an example, we had a staffing hiring freeze that year. We're coming out of the pandemic. Everyone was short-staffed. The manager was like, well, you know, I can't say that this person can see less consults per day because our volumes are up and our staffing is down. And so we had to come up with a creative solution with folks helping to cross cover, and also her relying a bit more heavily on a project manager that we had also helped her to connect with to allow that work to happen.
Thank you. That's extremely helpful. I like that idea of having sign off on the award letter, just from my experience. That's great.
Mm-hmm. Yeah, we really want to make sure that people do feel supported, not only from our team and obviously our executive committee, but also just from like their own personal local level as well to do the work.
Yeah, I know often
Yep.
staff are committing extra time, so it's nice that you support that. Sorry, Brad, I got a question.
Yeah, just, Catherine, I'm impressed with some of the analytics that you've walked these projects through. And I know that's not normally in the wheelhouse of most clinicians and academics. And so they've obviously gotten a lot of mentorship and coaching. And so tell me a little bit about, I guess I'll call them the teaching team or the mentorship that they get it. And that, who do you have on the team that is walking them through that? Is that the other, I mean, it seemed like a lot of people on that leadership slide that you had were clinicians and senior leadership within the medical system. Do they also have this sort of teaching background and some sort of this market and business analytics?
So that particular slide came from a faculty member who decided on their own to want to learn more in analytics and informatics, and actually now works at Google Brain. He's left clinical medicine and he's like completely in IT now. So that I think is a rare example of a project team member saying like, I want to learn how to do this. Generally, what we do have available for people is access to data reporting. So we do have our own data report writer in the Department of Continuous Improvement, of which Caring Wisely is housed under. And so that data report writer can pull EHR data, help validate it with clinical teams, can build simple Tableau dashboards to visualize data. More sophisticated data analysis, generally now we're going to our CTSI program for our biostatisticians. But generally we tell people up front in the Caring Wisely year, like, you know, you don't need to have like that p-value analysis that like, you know, the Safe Transitions Pathway team did. They did that because they wanted to publish it in this Journal of Neurosurgery. That is not like the minimum bar, the minimum viable product we want to see at the end of the year. That I think is above and beyond for sure. But the vast majority of our teams are not learning to pull their own data themselves. We have access to those resources so that they then can see the data, at least help guide the data report writers in terms of like, this looks right, or maybe we're not looking in the right flow sheet. Maybe look here instead.
And how often does implementation within that first year require some sort of a modification to the EHR and working with Epic? And
yes,
how difficult?
So
I know it can be difficult on our side.
Oh yes, always a challenge. And this includes the fact that we have our Chief Medical Information Officer, our Chief Nursing Informatics Officer, all on our executive and selection committee. So they are able to say up front, this is feasible to do in 1 year. I will help make sure that this gets done. And even then, sometimes there are delays, right? There are freezes and builds that delay implementation of the project team. But I would say like 90 to 95% of our projects do require some sort of EHR modification. Sometimes it is a major build, like a new functionality.
Right.
Sometimes it's a relatively minor build, like modification of an order set or an existing order, or modification of a note template or flow sheet. So we do vet what those builds are and whether or not there will be resources to get those builds done up front in the selection process.
Gotcha. Thank you.
Mm-hmm.
Getting the right people on your executive committee sounds like it's critical.
Yes. The executive committee is now about 20 members. So, you know, sometimes scheduling that meeting can be really challenging to get 90 minutes of somebody's time and then an additional follow-up 30 minutes to do the final selection. But what we have learned is if we don't have the right people at the table, it causes more pain downstream.
Thanks.
Don't see any other questions in the chat or Q&A.
Okay. Well, what I'll do is I'll just keep continuing. Maybe I'll describe the third project, and maybe by describing that, this is why I kept these slides in just in case. So this is an example of a project that a problem I'm sure exists at every health system, not just academic medical centers, but given the complexity of cases that we do in our operating rooms, there's just a lot of waste happening. And maybe there are some surgeons or peri-op nurses, pharmacists, techs here on this call. But I remember witnessing this as a student and kind of thinking, this seems weird that so much gets thrown out or not used. It gets brought into the room and needs to be sterilized and reprocessed. And then I led neurosurgery QI for 5 years earlier on in my career. And I spent a lot of time in the OR as part of that work. And that's really when my eyes got open to this problem. So the lead for this project is an anesthesiologist, Dr. Seema Gandhi, and she's now our Chief Sustainability Officer at UCSF. So that's a role she got in our health system because of the successes that she had in this Caring Wisely year. And the problem was, people who work in the OR, they're not people who want to trash the environment and cause global warming. Like, everyone agrees that OR waste is a problem and they want to do something about the problem. And yet, we know that there are a lot of supplies that get unused. And this picture here is just the number of supplies and trays that were unused after one surgery. Not even like a whole day, just one surgery. And we've got 30 ORs going at one time at this one campus at Parnassus. So a lot of time was also just spent in terms of human resources, restocking these items. And so not only was it an environmental issue, a cost issue, but also a human labor waste issue. So what they wanted to do was decrease supply waste and cost per case in a couple of targeted surgical service lines, including our kidney transplant service line, spine service line, general surgery, laparoscopic robotic, and as well as the labor and delivery cases. And this is a simplified gap analysis, but a couple of the big things they found was over preparation. The techs and nurses really wanted to have everything possibly in the room in case something went wrong. Because, if something does go wrong and the surgeon gets a little bit testy, the nurse also doesn't want to get yelled at as well if that key scalpel or a key retractor is not there. A lot of supply duplication because these preference cards that I'm fairly certain you all probably use at the University of Michigan as well, they get entered into the Epic system, but they don't really get updated in so much that people go through them and say, yep, don't need that anymore, don't need that anymore, don't need that anymore. They only get updated in that surgeons say, oh, I need this, I need that. So they just get added to rather than subtracted from. And what ends up happening is these large preference cards that the techs and nurses use to know what supplies and equipment to bring into a certain room for a certain case get very bloated. And there aren't any waste audits or discussions to raise awareness, and people don't really even know how much some of these supplies cost. So a lot of different interventions happen. And here's a picture of Seema with one of our kidney transplant surgeons reviewing Dr. Frace's preference cards. And you can see that there's like a lot of review of preference cards, supply lists that are happening. And we did this with all of the different service lines. We also decided that we needed to create not create, but like reduce some of the supply packs that were coming into the operating room. So an example I'll give that also has a slide coming up is that our spine surgeon said, our spine pack has so much stuff in it. I don't use all this stuff for my minimally invasive spine surgeries. And he was like one of our top volume minimally invasive spine surgeons. And he said, wouldn't it be great if I had a supply pack that just had the things I needed so I didn't have to throw away 10 pounds of stuff at the end of each case? So we worked with our supply chain procurement team to actually get him the pack that he needed. So examples of all of the different interventions. So here's an example. We've created this minor spine pack. It costs less than the major spine pack. diverted about 913 pounds of waste per year, which I think is really huge from an environmental standpoint. And also, I mean, although the cost savings weren't that huge, $20,000, it's still some cost savings just for one type of surgery. We also were able to do this with several other service lines as well. The review of the preference cards with the high volume surgeons was huge in eliminating a lot of the waste and bloat. We also found that at least in labor and delivery, they were not charging for their supplies. And so there was an opportunity to get paid for the things that we were actually using. And so our revenue and finance team was kind of excited about that finding. And they were also able to reduce some of the supplies they were actually stocking on the unit that they didn't even need and stop buying them. This functionality is now in Epic. So if y'all aren't using it, then something to think about. So this is basically a surgical receipt. We call Epic Apex here because, you know, we have to rename everything, but it is in Epic. And essentially what it shows per surgeon is based off of your preference card. This is how much the things that your opening costs. These are the things on your preference card that you list as needed or PRN. That's how much that costs. This is your total cost. Your group that you work in, this is their overall total cost. So for some reason, this surgeon's preference card cost is higher. So it might give them the impetus to be like, should I take stuff off of it? Should I rethink the types of supplies I'm using and use the lower cost op? It works just as well. And you can see there is like one surgeon who's doing laparoscopic donor nephrectomies, so taking out the donor kidney to then transplant to the recipient, who has like a preference card that is fairly lower. So it allows for social gamification, again, just like cost awareness and that audit and feedback of data that's more automated and used to be a lot more painful to pull, but is now functional in Epic, which is nice. So in conclusion, I hope I've demonstrated to you that people who work on the front lines are really eager partners to improve value and reduce healthcare costs. They just need the time, the right coaching, the right access to resources. And we feel that we've established a program that is effective at allowing folks to do this work. And achieve meaningful cost savings to our health system, which is why we continue to be supported to run the program. And that is it in terms of the slides I got.
Thanks, Catherine. It looks like we do have one question from Tammy. She asks, should we use some case study or one page? Oh, she's saying, didn't mean to send that to the group.
Oh, okay.
I don't know if anyone else has any questions. I think this is, oh, Kendra, if you have a question.
Hey, my name is, I'm Kevin Chan. I'm the Vice Chair for Clinical Experience and Quality at the University of Michigan. Really appreciate your discussion, Catherine. And I just wanted to, you know, what you do is what actually Tammy Ellis is our Manager of Quality Programs for the department. We have about 12 people in our section that does exactly what you do, except for the Department of Medicine. We wish we had $50,000 a year to allocate, but we, in general, have a much smaller amount. We do provide effort, and that question was about, and we, in general, provide it to people with ideas that are clinicians. So they're the ones that have those ideas. They're the frontline people that see boots on the ground, flow, quality issues that they would like to address. And we provide the support with our program managers, our data analysts, to give them that information and 1 year support. And several of our projects have moved on to much larger items, such as our penicillin allergy program. The other is medication monitoring programs. Several of them readmissions for cirrhosis. These are huge impacts, and so we really congratulate you on your project. We would, and we're very focused and are always looking for more support within our department to do such things. So I didn't know if Tammy has anything to say, and we're really interested in your progress and your innovations, and we congratulate you on such wonderful work. Thank you.
Thank you, greatly appreciated. And, if at any point you want to reach out, I can put my email in the chat. Should have had it on a slide as well, but, feel free to reach out. I'm happy to collaborate, and I feel like there's always opportunities to learn from each other. And, the $50,000, that was the result of a lot of back and forth negotiating with the health system. And eventually it was the Center for Healthcare Value who said, you know what, we're just going to fund this for you. We're going to give you $150,000 and you do it with 3 projects and see how it goes. And it was after that first year, the packed red blood cell transfusion project, it's like, 12 years old now, so I didn't highlight that one as one of the results. But at that time in healthcare dollars, we achieved within 1 year $725,000 of direct cost savings. So that alone way more than paid for the 150 investment. That really blew, the eyeballs off of like some of our C-suite executives. There was another project that year as well at transitioning aerosolized nebulizers for patients admitted with like asthma exacerbation, COPD exacerbation to meter dose inhalers while an inpatient, just as effective, and also has the opportunity to educate patients in how to use their MDIs correctly as an inpatient with a respiratory therapist. And that project also produced about $150,000 of direct cost savings as well. So it was after that pilot year, and ever since then, the medical center has happily continued to put forth the money to support the projects.
Right. So that is budgeted every year.
Yes, it's budgeted every year. Mm-hmm. And we maintain communication with them. This is part of the quarterly executive committee meetings. We don't want to just come to them every year and be like, hey, where's our money? So it's a back and forth communication, and so that they know what work we're doing, and we also understand where their priorities are.
Great, thank you.
Yeah, I just wanted to say I work with Kevin, and sorry, I was like chatting and we were getting excited about how you were presenting your work, and really, really great things there. And I really appreciate and like how you've put money to a lot of it, because I think that's really important, and it's something we don't always think about with QI projects. So congratulations, that's great. I may reach out to you for more information. Mm-hmm. Yeah,
sure, absolutely. Yeah, the money was important. Again, the return on investment quality is really important, absolutely. And in order for the CEO to say, yes, we're going to continue passing this line item in the budget, he also wanted to make sure there was some return on investment. And there are other things we report to our executive committee too that I didn't include, but publications important, faculty development, staff retention, super important, especially in this era of burnout. We strongly believe that doing this sort of work, developing people, developing their ideas, really helps with burnout and allows for a more fulfilling career and job satisfaction. And we measure that in surveys. We also have an end of the year survey as well, where one of the questions asked the teams, did participating in the Caring Wisely program allow you to be more of a positive change agent in the health system? And every year the scores are very high. So the health system really, appreciates that as well. And many of these folks end up in medical director, nursing director, quality director, or some sort of director positions afterwards.
Well, thank you. I do want to just mention that our Innovation Challenge submissions are open until Friday, and we do have we award 2 grand prizes, and one is for QI project in the cardiovascular space. So if anyone has any questions about that, please feel free to reach out to me. We also have our Just Do It awards, which are
funding available.
Yeah, funding available for the larger
$50,000.
awards and the smaller awards for around $5,000 each as well. So if you would like to submit, please reach out. We'd love to hear from you. And well, with that, I will end it and let everyone get on to their next meetings. But thank you so much again. This was wonderful, and hopefully we can make some future connections and work together.
Great.
Thank you,
Thank you.
Catherine.
Bye.
Bye.